Okay, we will start the next case. I think we have a live case now for the TEER, and we are excited to have
Can you hear me?
Oh, yes, I can hear you.
Oh, yeah. We are somewhat late because of previous case, very exciting.
Oh,
So
yeah.
wait for 5 minutes.
Yes, I was also seeing by the Zoom and was excited.
Yeah.
Yes.
I'm Jung-Sun Kim, Severance Aspirant University. I'm co-chair is Samir Kapadia, yeah, from USA. We also invited a panelist, Daisuke Hachinohe, Joo-Yong, Geu-Ru, Byung, Shunsuke Kubo, Simon Lam, and Takashi Matsumoto, and Takao Morikawa, Shih-Hsien. So please, at first, please introduce your team and case, please.
Thank you, Dr. Kim. I'm Dr. Do-Yoon from Asan Medical Center. Here is the hybrid room of the Asan Medical Center. And this is our team, strong team for the TEER. Is the Dr. Gossadi from Saudi Arabia, the senior fellow of the interventional cardiology, especially for the structural heart disease. And my mentor, Dr. Dae-Hee Kim, the imaging specialist, and Dr. Ho-Young Kim, and Dr. Yang Ji-Yoon for anesthesiologist, and our strong team is waiting for the live case. And Dr. Gossadi, can you please present our patient?
Sure. Thank you very much. I'm Dr. Gossadi from Saudi Arabia. Our patient today is 77-year-old female, has been admitted due to worsening dyspnea. Echo showed severe functional MR with mild LV dysfunction. So TEER procedure is planned for treatment. Past medical history are remarkable, a part of chronic kidney disease and atrial fibrillation. Next. Her body mass index around 22. Patient admitted and treated firstly with inotropic support and IV Lasix and aldactone, and after a while she improved and then shifted on oral Lasix and aldactone and also some beta blocker and anticoagulation. Next. ECG showed atrial fibrillation. Next. Chest X-ray, some cardiomegaly. Next. CT coronary showed mild coronary artery disease, which is treated medically. Next. Now Dr. Kim will interpret the echocardiography.
Yeah, this is initial echo occurred at emergency room, April 18th. As you can see, every temporal side slightly increased for body surface area. Ejection fraction was mildly reduced to 44%. RA volume index was 102 milliliters per square meter, hugely dilated after atrium, and there is no regional warmers. Next. As you can see, there is severe mitral regurgitation. The etiology seems to be atrial functional MR. Next. The RV function was slightly decreased, and the TRV max 4.3, indicating severe pulmonary hypertension. Next. After aggressive medical treatment with IV diuretics, we did 8 kilogram of volume reduction. Even after volume reduction, he was still dyspneic, EF function equals 2 or 3. LV dimension was 38 over 50 millimeters, slightly decreased from the original one. Ejection fraction was 46%. Next. The degree of MR slightly seems to be decreased, but I think still moderate to severe functional MR. Next. The TRV max remarkably decreased to 0.8 meter per second, indicating no evidence of pulmonary hypertension. Next. We performed a transvaginal echo the next day. As you can see in esophageal four-chamber view, the pizza radius is 6 or 7 millimeter, but in patient with functional MR, usually pizza measurement underestimate degree of functional MR. In bicommutaral view, you can clearly see a diffuse MR jet in according to the coaptation line. And next, in 3D view, you can central coaptation defect and diffuse MR jet according to the coaptation line. Next. In patient with diffuse MR jet, we have to measure vena contractile area using 3D MPR imaging. The measured vena contractile area 0.78 square centimeter, indicating severe AR. The estimated measured 3D mitral valve area using MPR image was 4.2 square centimeter. We can use at least 2 mitral clip. In left upper pulmonary vein, definite systolic reversal was observed. Thank you.
Yes, let me summarize the patient profile. The 77-year-old female, a small female, 150 centimeter, with a long-standing atrial fibrillation and CKD, and worsening dyspnea, and she visited the ER and could not be discharged with inotropic support, IV diuretics, but still has a strong dyspnea and severe atrial functional MR, and accompanied the TEER with a pulmonary hypertension. This is a very typical situation in atrial functional MR patient we meet. As I presented in this morning, in our center, we did the 14 atrial functional MR TEER case, and the usual age was late 70s, and ejection fraction was okay, but the LA size was really big, and the tricuspid annulus enlargement is accompanied with a severe TR. And moderators and panelists, do you have any idea, or can you please share your experience?
No, it's a great case, and this is Samir. I was just wondering, do you have pericardial effusion also, or this was just on the echocardiogram? Do you have some pericardial effusion, or this was not a pericardial effusion or pleural effusion?
Yeah, but pericardial effusion, right? But initially there was a high airway pressure with severe TR. After 8 kilogram of volume reduction, slightly decreased, but we have to keep an eye on pericardial effusion. But there was no hemodynamic significance right now, maybe, yeah.
Okay.
Do-Yoon, this is Hahn from Samsung Medical Center. The LV systolic function is mild, but why is the patient do-vitamin dependent?
Because initially he had decreased airway function. When we using aggressive diuretics treatment, we usually support with inotropics. After then, the do-vitamin taper out. We did successfully 8 kilogram of volume reduction before the play.
Yes.
But LV systolic function is mild, and this patient has atrial fibrillation, so I think do-vitamin may aggravate the
Yeah,
heart
usually
rate
most of
or MR.
physicians think so, but usually a small dose of do-vitamin 2 or 3 microgram per kg per minute does not increase the heart rate and support the airway function and successfully IV diuretic therapy as a potential can be potential after do-vitamin infusion.
And Dr. Kang, I'm from in the university, Dr. Kim.
Yes.
This case looks like so-called atrial functional MR. So
Yeah.
clinical outcome is very important for management of atrial fibrillation. Do you have any plan to atrial fibrillation or catheter ablation?
You mean the catheter ablation? But however, the patient already have the very long-standing atrial fibrillation, and LA size is very huge, maybe more than 100 millimeter, maybe. And because the patient is Dr. Kim's patient, and he take care of the patient over 3 weeks, do you have plan to overlay the atrial fibrillation or her?
Not at all. Currently, but after MR reduction, the LV reverse remodeling continues, and then at that time, I will consider later. But yeah.
I have some question to the panelists that if patient has the pulmonary hypertension and severe, not severe, but significant TR with pulmonary hypertension, if we treat the MR, will the pulmonary hypertension and TR relieve, or will we need additional TR procedure? Do you have any in share?
I'm Geu-Ru from Severance Hospital.
Yeah.
Actually, in this patient, how many days you use diuretics and dobutamine therapy? Is it 1 week?
Almost 2 weeks.
2 weeks. After 2 weeks treatment, TR is dramatically decreased, and the pulmonary hypertension is almost disappeared. So in this case, it's not a big deal to use a TR, but in some cases, even 1 week or 2 week aggressive therapy, pulmonary hypertension is still 50 or 45, or TR is 2 or 3. At that case, that is really deals. So what do you think about in the panel?
No, I think you can still, at least in our practice, we treat both the MR and TR at the same time and close the interatrial septum if TR is significant. But again, if this patient, the TR is better, I am kind of, little bit surprised that, so much dobutamine was needed. I agree with that. So there is a possibility that patient has amyloid or something like that. Is another possibility with the QRS is where kind of small, there is pericardial effusion, and the patient has large atria. So this is a consideration in my mind that this could be a amyloid disease of the heart also. I don't know the patient super well, but I'm just thinking that these are the possibilities that you would consider.
Yeah, I agree with Dr. Because this patient is, even she has a really bad atrial function, but also she has a really big left ventricle and ejection fraction very low. And but in the heart rate is a slow ventricular response.
Right.
So in that case, this patient's cardiac output is very decreased. So dobutamine can help those kind of situation. Yeah.
Okay, let us go ahead and start the procedure because we don't want to delay it.
Yes. We did the septal puncture, and now the catheter is in. And can you please show the current situation of the valve, and let's talk about the valve clip selection.
Let's looking at bicommissional view. The diffusion MRZ is thin, but our initial plan with XCW clip in the central arterial region first. After then, second clip will be considered.
Then Dr. Kang,
So what is the LA pressure? Did you measure it?
Oh yes, can you please show the LA pressure? Yeah, we recorded it. Okay, let's wait. Can you see the LA pressure there? Can you 프레셔 한번 올려주시겠어요?
the yellow line?
The green line.
Green
You can
line?
see.
Yeah.
Now we
you
see,
yeah.
Yeah, you can see it's a recorded image, and the peak pressure was 30, and there was a significant V wave about 20.
Okay.
The peak V was 30.
Go ahead.
Yeah. And
Already catheter in.
yeah, actually, we selected the XCW, and I think that all the panelists has a different and various opinion about that. But in our echo, the posterior leaflet length was sufficiently long, 50 millimeter, and the valve area was large, so we selected the bigger and larger XCW to.
No, I think this is a good idea because with a large posterior leaflet and dilated annulus, XT is a good choice. But sometimes for functional MR, people use NT, but not this kind of patient.
And because the area size is very large, the imaging is distorted. And now I'm coming in. Can you please show the tip of the clip?
Okay,
we
yeah,
are
already in, and nearby the Q-tip, yeah, is going down smoothly.
Okay, I will go down.
Yeah, let's move to biplane imaging.
Yeah. The image is totally different.
Much
compared to
rotated
usual image.
the usual one.
Dr. Kim,
Yeah.
what is the position of the transseptal puncture? It's a mid posterior?
Can you please review the puncture position?
Yeah, puncture position is slightly posterior from the annulus. Posterior and inferior.
Oh, inferior.
Yeah,
I think it's a good idea.
We have to puncture inferior because the
Posterior superior, the septal puncture is
high,
more than
yeah.
7 or 8 centimeter.
Okay. And now I'm just in front of the valve. Can you please rearrange the image?
Biplane. Okay. Still L-dive.
Yes. How about this trajectory, do you think?
So where is
looks
the
good.
exact target? Just the central?
Central lateral.
Central lateral.
Central.
Lateral, yeah.
Here. Yeah. Can you please show the Doppler? Here is a
Okay,
target.
right over there.
Yeah. 아래요, please.
Okay.
아래요,
Of
shallow
the
아래요.
color.
Yeah.
Please check trajectory again.
Yes, trajectory, check. In atrial functional MR, imaging is somewhat difficult because area size is too big. Valve and LV looks so small. Here is my trajectory. Do you agree with this?
Yeah,
Slightly
trajectory is
posterior.
good.
It's good.
Yeah,
looks
good.
A little bit anterior I will move.
Yeah.
Okay? Do you like it?
A little bit, please. Better than before.
Okay.
Yeah.
And then I will open the clip.
Clear.
Clip up. And we'll check
Okay,
the
let's check the
orientation.
3D.
Oh, it looks good.
Oh, NPR.
This is the NPR image. But I discussed with the Kim. He does not like it so much. How do you think about that, Kapadia?
I think
Yeah,
you can
slightly,
clock it
rotate
slightly
clockwise.
clockwise, yeah.
Right, clockwise place.
Clockwise.
We I'll take 6-12 o'clock direction.
Yes, the atrial annulus looks spherical, so very hard
Very far,
to
yeah.
make a good orientation.
Yeah. Okay.
Do you like it?
Yeah, I think
This-
it was
this-
good. But
yeah,
we
this
should know
orientation?
which one is the anterior and posterior.
Okay, let's take a grip up,
Check the gripper
both down
and the dotted gripper.
and posterior.
Posterior.
Right.
Okay, close the clip.
Then I will go in. How do you like the position? Isn't it too central?
Slightly, slightly move toward the lateral.
A little bit
position.
lateral.
Oh, where is the clip? Yeah, we move laterally.
Move more.
More. Okay, looks good.
Okay.
Right over there.
Go in like this.
Yeah, go in. Trajectory is good. Better than before. Slightly L-dive. Yeah.
Okay. I will arrange. How about this? Isn't it 2M?
But 2M.
Yeah.
2M number was applied.
Because there's some calcified coda maybe. There's some artifact there. Okay. I'm going in.
Okay, slightly M.
Still slightly M.
Yeah. Okay, good. Oh, but the anterior leaflet seems to be entrapped.
Yeah, it is
in the
always-
Yeah.
Oh, I did not do so much, but
I don't know how that happened, but your grippers are still up, right?
yeah, still up.
Yeah.
Well, I don't know why.
Oh yeah, let's see.
So just go posteriorly with the clip.
Clip open slightly. Yeah, that's
Yeah, but
open,
that's
open.
fine. Just go posteriorly. Turn.
Yeah.
No, it is stuck.
Yeah, stuck in the anterior.
Yeah.
I think you,
Yeah,
you should
move,
open the
move
clip a little
posteriorly.
bit.
Open.
Open the clip.
Open the clip. That 30-degree, please.
Yeah, this is unusual.
Yeah, unusual situation. I agree.
Don't pull back so much because
Yeah.
I think you are.
Yeah, just
Open the
just
clip
opening it.
slightly. Yeah,
Open the clip.
Open the clip, please, Dr. Kang.
Okay. I open the
Keep
clip.
open the
a
clip.
little
Yeah, and now try to go in first. Gently.
Yeah, stuck.
bit. Oh no, it does not go in very well.
What about moving the clip
And
centrally?
make it.
저 위에 조명 좀 꺼주시겠어요?
Why don't you invert clip?
Yeah.
Please
Evert.
invert the clip.
I will move slowly. Okay.
Okay,
now
there
Oh,
it
yeah,
came
yeah,
out.
yeah,
It came
yeah.
out. It came out.
Yeah, came out.
I
Now
just
check
opened
the.
a little bit more.
Yeah, and now check the grippers one more time.
Yeah.
Just to
Yeah.
make sure that they are functioning.
I will begin again from the trajectory. Because I moved a little bit M and L inside the LV, so that would be the cause. 다시 한번 보여주시겠어요? 트라젝토리부터 볼게요. Can you please show the biplane? Okay.
Maybe check on the 3D, the orientation, and
Yes.
because it's a little bit far, I think, too far lateral.
Yeah, slightly L dive.
Here, how do you like it?
Oh, okay, looks good.
Okay, I'll try.
Let's take a 3D orientation
this angle
again.
again and grip up. And check 3D again. I'll go a little bit higher.
Slightly smaller box on the 3D may be better, yeah. So you see.
3D please.
Okay. Counterclockwise, please.
And we need more location.
That's good, but it's slightly, I think you can come a little bit medially
Yeah, please move medially.
and slightly.
Oh, it looks better. Yeah,
Like
okay.
back and slight clockwise, I think.
Yeah.
Yeah, agree. Okay, let's
Better,
move
yeah.
to biplane image again.
Do you like it? Okay. And here I will check the gripper again.
It's good.
Goes down.
Good. And the
Cross
posterior
here.
also moves well. And I will go in again. Do you agree with this position, Dr. Kim?
Yeah.
Slightly move laterally.
A little bit lateral?
Yeah. Let's on the
You
curve.
mean here?
Okay,
Yeah,
okay,
good.
okay.
Good.
Good. That position is good. Okay. Up the curve.
Okay, I'm going in.
The slightly posterior.
No, it's
tilt
good.
direction.
It's good.
Yeah, it's good. Right now. Yeah.
Go in a little bit more and then open it.
Okay, good. Looks good.
Open.
Okay, let's take a 3D orientation right now.
Yes. But I cannot clearly visualize the leaflet.
It is a little
okay.
too clocked.
Yeah.
It's fluoroscopically, you need to clock it a little bit.
Okay, please
agree.
rotate it clockwise.
A small movement.
Clockwise
black,
a little bit.
here.
Okay.
Yeah, that's better.
Okay, let's focus on the good 2D image. Okay. I think the reflect is already on.
Is it the lateral position is okay? Do I need to
Yeah.
go more lateral?
No, I think it's good.
Yeah.
How about
Let's
Yeah,
go a
let's,
little anterior though, because I think the anterior leaflet is not.
you move to lateral position. Yeah, according to the color location.
Okay. How about here?
Posterior.
Oh yeah, the line is not good.
Imaging is very challenging for this
Yeah,
patient.
especially the visualize the both leaflet right now.
See the TE probe, if you advance it, you will not have the shadowing because you're looking right
Yeah,
through.
yeah, I know, but I advanced the, yeah. Better than before. Okay,
In the
so,
fluoro, you can see the TE probe right behind the clip.
yeah, let's check the 3D orientation again.
Yeah. The difficulty is that I cannot see the posterior leaflet. Yeah.
Okay, please
little bit.
move
Okay.
counterclockwise.
Remove.
Okay. Good.
Counterclock.
Okay. Let's move to biplane. Okay, better than before.
The anterior looks good.
Yeah. A posterior leaflet.
It
is not
should be there,
visualized
yeah, but it's
well.
just the shadowing because of the.
Yeah, I think the
You
probe
mean
should be advanced,
Yeah, I
gastric
advanced.
view or-
Yeah.
and we can check the posterior leaflet.
Yeah. And also,
Don't lift
furthermore,
up.
in
I
this
think
view,
go
it's
inside.
not
Can you?
biplane. Yeah.
Okay,
Yeah, more
right now
inside.
it's okay.
Okay. Much
Yeah.
better.
Yeah, that's better because if you see from the probe how in the fluoro it's below,
Yeah, this
so
is
you can
fluoro.
see better.
Real time. Yeah.
And now go little posterior with your clip, so you can catch the
Okay.
posterior
I'll
leaflet.
wait.
Okay,
Yeah,
let's check a 3D orientation again.
yeah, that's
Before
better.
grip down. I think the both leaflet are already on.
Yeah,
It's on.
Oh, looks good. Yeah.
How about the anterior leaflet? Is it
Yeah, already.
on?
Yeah, I think the
Sufficiently
anterior
on.
missed.
it's okay. I think
Now,
Can you agree down the grippers
one more time.
one more time?
little higher.
Okay.
Until it's not on. Oh,
Anterior is not on.
Yeah, it is on. It is on.
Is it on or not? How do you
I
think?
thought it
Okay,
was
please
on
visualize
because
more. Not on, I think. Okay.
So if you
Very challenging.
okay. Now it's good.
lift up the clip.
Now it's on. Oh, anterior is not on.
Okay. Anterior is. Please focus on anterior.
Oh,
Posterior.
it's dangerous. Posterior is on, but I cannot guarantee that anterior is on or not.
The reason is that the biplane view is not
Yeah.
perpendicular, so that's why you cannot see both leaflets at the same time.
Okay.
So if you want to catch one at one time and then show the other one and you catch the other one. So if you want to see
posterior
the
is on.
posterior,
Yeah. And see the anterior in another view.
Okay. How about this? Okay.
Okay, let's see anterior leaflet. I will go.
both
down
are
a
both
little
are
bit.
good, I think, at this point. You just don't see them, but they're good.
Oh, grip is down. Yeah. Anterior is not.
No, it is in. It is in. What you see is a cord.
Oh, no. Anterior is not.
Oh, now it is now. Yeah.
Yeah.
Okay.
What about focusing on LVOT view instead of X-plane view?
Yeah, I agree.
The better way is to do a 3D and MPR. That is, if you can do that, live MPR with 3D, then you will see both.
Always imaging is more important.
Imaging is very important.
Before having the view, can you please?
how about this
Can you
view? Yeah.
check the 3D view again? I think it's a little bit rotated.
Okay. It's 3D.
Then
Sorry.
Can you do an MPR there? Oh.
Okay,
yes,
I
we
will
can.
try
Yeah.
MPR.
Box is, yeah, if you make it smaller, you will see. Okay, that's fine. Now do
Okay,
the,
looks good.
and do the MPR here.
Yeah.
Yeah, and now put the green plane on the clip, so you will see the clip, or red, doesn't matter. Do you have the planes there? You can see them?
The problem with the impairment is 2D is not good as much as usual one.
I think that the MPR
Now you can see it where it
You
is.
can. It does looks okay.
Mhm.
And the right upper
Let's
plane, I can
move to
see
my plane
the
again.
post leaflet.
Yeah, it seems to be on.
Yeah.
How about the anterior leaflet? Is it on?
Anterior is shadowed, so you can't see it.
Okay.
If we go deeper, and it will be seen again.
See, it is below the clip, the anterior.
Yeah,
leaf.
Dr. Kim. So you should pause the TE to make sure the anterior leaflet.
Can you say again?
Just a pause. Pause the TE.
Poor, yeah, but deep.
Now it's too deep, and this position is good to make sure the posterior leaflet, but not good for anterior leaflet because of the interfere of the shaft. So you should make sure individually posterior side and right anterior side.
You mean let's move to single plane imaging?
Yeah, and more for the.
Okay, now it's good.
Here it looks better.
Excellent.
Now it's good.
I can see post leaflet
Okay.
very well.
It's good.
Too much up. Okay. How about here?
Until it's not on. Oh, yeah, that's okay. I think you move the clip system anteriorly.
Okay.
Yeah,
Then
better than before. Yeah. Now it's good. Now it's good.
down, please.
안티를 조금만 더 태웁시다.
안티를 좀 더요. Okay, some more.
Okay, anterior is not good.
Anterior is in? I don't think so.
Yeah, I think not.
Maybe do two more dose diffraction and prepare the TE probe a bit.
I think it is.
So if you want to make sure anterior clearly, you should pause the TE more longer and give the retroflex.
Okay. Now it's better than before?
Yeah.
Yeah.
Imaging is challenging. So.
Yes, you're changing.
I would say it's very difficult because the commissioner by commissioner view is not at perpendicular, and then you can see both leaflet on the
Exactly.
side. I may consider because higher up of T you can see the anterior quite nicely, but I would first lower the posterior at the T probably is here, and then go up to check with the anterior.
Dr. let's move to single plane imaging.
Yeah.
But first maybe optimize the TE first.
Yes.
Because I would also like to know how much leaflet I grabs. It's not just touching the leaflets.
I think try the higher up view as he's suggesting, because I think we already tried the lower one.
This way is good.
Yeah, so just catch the posterior and then you can swing it to the anterior side.
Yeah, slightly anterior. Okay, better than before. Yeah. Now it's good. How about this location?
Go a bit posteriorly.
Yeah, just get the anterior one only.
Yeah.
It's good.
No.
Anterior is out. Anterior is out.
No.
It's out, I think.
It is
Try
out,
once
yeah.
again to have me. Second.
Dr. Kang, let's take a 3D unpassive view again.
This is rotated.
Yeah, maybe rotate. Okay.
I think a smaller box and a 3D MPR stay there. So you
Okay,
might be
let
able
me
to
try.
This position is very good.
Yeah, better than before.
Clip angle is nearly 180, too wide, a little bit wide.
Okay. Okay. It looks okay. Okay.
Okay, that is
I'll
good.
try here.
But interior is not. I think you can open the clip to 180, and then you can try to withdraw the clip
open the clip
at
more.
the surface. Yeah, you have to observe the
Oh, yeah,
surface.
it's slightly inverted.
Yeah, it's too much.
Too much. Yeah. Oh, that's okay. Okay. Right now, how about?
Perfect.
How about anterior? Is it in?
No,
Not yet,
advance
not
a
yet.
bit, and then
Keep the
try to
panel
pull
looking.
back as its surface.
That was good. That was good. Okay.
Okay, good for Young.
Yeah,
no
the posture is
Oh,
out.
no.
Or you can try to use the pip. Maybe it can work.
네네.
Okay, that was good. Oh.
No.
Okay, anterior
How about
is
the
in.
anterior?
Yeah, I think anterior is not in.
It's out. Anterior is out.
Would you want to try increase the pip?
Okay.
Can you increase the PIP? 지금 PIP 얼마예요? The pressure PIP 얼마? 조금만 올려주세요.
Okay, we are increasing the PIP.
Perfect.
Yeah.
Okay,
It's better.
that's good.
Yes.
Okay. Yeah.
Yeah.
Oh, yeah. Good. Yeah. Anterior. Yeah. Insulin. Yeah.
And close.
Please
Okay.
clip slowly.
This is a 60-degree.
Okay.
Let's review. Please, not very close.
Full course, please.
Okay. Now it's pretty close.
Yeah, now it's good. We don't need any more clip.
And a little bit release the tension.
Okay, let's check the clip insertion. Oh,
You can see the set.
problem is anterior. Oh, okay,
Yes,
that seems to be okay. I would like to ask the panelists, how about the insertion of the anterior and posterior? Posterior is sufficiently inserted, but the problem is anterior is not good as expected.
It looks okay because
I
it's
see it.
It
tight.
looks okay. Yeah.
Anterior should be fine.
After the gripper down, so anterior gripper was bouncing so much. So I think insertion should be good.
Yeah, okay. Let's check the pulmonary flow.
Samir, one question. In this case, is it possible to use independent grasping?
That's what I was saying, that
Yeah.
independent grasping is sometimes better.
Yeah.
What I like normally to do is to image everything with a 3D MPR. So don't go out of the 3D, stay there and align the planes. Keep the box very small. If you keep the box very small, you can have a very good resolution. So you will see exactly like what you're seeing on a 2D. And then you can align
Yeah, pulmonary flow is normalized in left upper pulmonary vein.
And how long do you often use the independent
You can check
gripper?
Yeah.
That already a sec.
No, it is already has good, you have good result because you can see it that there is smoke in the LA. So
How about 3D view?
Yeah. 3D view, okay.
Yeah, tissue bridge.
what is the gradient also? You will check it after.
All right, let me check again after 3D imaging.
Sure.
You mean the small 3D
Small,
box
yes,
improves
small
the
box.
resolution?
Yeah, and like again sideways. See, it's so long, big. Yeah, keep coming down, come
Okay.
down.
Oh, yeah. So let me check it.
Still the imaging is
Wait a minute.
challenging.
Yeah, the sharp to shadowing. Oh, okay. Let me check again. Now it's good.
Yeah, better.
Yeah.
So you see the
The
medial
location is good.
side well, the lateral side you don't, but that's okay. Now put some, and go ventricular side to see where it is leaking. Yeah, and you can trim it, the ventricular side. Yeah, put some color there. No.
Do you want to apply some color flow imaging? Or
Yeah, just to try to understand the pizza, that how big is it. It's leaking very little there.
The MIZ.
Just slightly lateral to the clip. There is a slight leak, but not much. I think
Let's check a pressure gradient right now.
Yeah.
It seems like maybe 2 or 3. The acceleration colorful. Yeah, maybe longer one. 2, maybe shorter one, 3 and 2.5 millimeter mercury maybe.
Yeah. And the pulmonary flow reversal was normalized and the sec developed.
Sec in the array.
And the pressure gradient is okay. And we check the anterior and posterior leaflet is well aggressive.
Yeah, slightly some MRZ in the lateral position.
And in this situation, do you guys wait some moment or just deploy?
You could deploy. The only thing to do differently, and I am afraid of saying that because I don't know how easily you can. So sometimes this kind of jet just next to the clip could be corrected by turning it one way or the other. But I think we have difficulty imaging. So the fine movements are going to be difficult to do. So I think you may want to just deploy it.
So
I agree. Slight.
Is the patient on dovitamin now?
No,
not yet.
No dovitamin.
No dovitamin.
And blood pressure is 130, maybe about 20 millimeter mercury increase.
Blood pressure goes up after
clipping.
Yeah.
If you lift up the probe a little bit further, can you go up higher now with the probe? Because then you can potentially align it. Those
higher.
Okay, align is better than beeper.
Right. You won't see the leaflet, but at least you'll see where it's leaking.
Yeah, just that. Not much MR from the right side.
Then, shall I deploy?
But before, if we can appreciate those kind of remnant MR, just close to device, after release it.
It might be
increase. Bigger.
I agree.
So I really worried about the clip is a little bit angle is a little bit is not true,
But I agree. But I think they have a very hard time seeing it. So I think trying to change it now because this is a good result for the situation we are in. And the reversal is gone. The LA pressure is less. Gradient is not high, so you can accept this result. I think
it depends on operator and Dr. Kim is your patient. You should decide.
You decide.
But if we can move clip more laterally, we can.
So after this clip, and I think we can watch the result. It's better. So
if you want to just reduce 70% of the amount of MR, I think it's acceptable result. So I think you can release it. What do you think, Professor Kim? What do you think? Is it okay?
But after release, the MR increase do you think we can put another clip lateral position?
Yeah, that's right. That's right.
That's correct.
That's another
Yeah,
option.
Okay, let's
Yeah,
keep
so I
going.
think we have some limited time. So we have one lecture, feature lecture.
Okay.
Then
During
after
the
the feature
lecture, I will
please
finish everything.
show
Yeah.
the final result. Yeah, so
Yeah.
I would like to introduce Takashi Matsumoto, Shonan
소리 안 나가죠 이제?
Kamakura General Hospital, Japan. He will give a talk TEER for atrial functional MR, a new weapon for emerging target. Takashi, please.
Thank you very much. I'm Takashi Matsumoto from Shonan Kamakura General Hospital. So this is my disclosure slide. So atrial functional MR is very important type of MR. So recent study showed the significant atrial functional MR was present in 6 to 7% of patients with AFib, and its proportion in heart failure preserved EF was up to 53%. So it's not a rare disease. But unfortunately, we don't have enough evidence for treatment option. Then when we see ACCH guideline 2020, it's recommend mitral valve surgery for atrial functional MR, but it's class 2B. And the mitral clip is not recommended in this guideline, but in real world, we use it and it works very well. And this is a sub-study from EXPAND study. It's reported that this figure shows severity of MR after mitral clip, and it shows in both group, atrial functional MR left side and in ventricular functional MR, in both group, MR reduced significantly, and the reduction of MR looks like similar in both group. And let me show one case in my center. She's 82 years old female, height is 148 centimeter, and weight is 37 kilogram. It's very small Japanese lady, and her past medical history is hypertension and CKD. And in 2015, moderator MR was pointed out, and last year admitted to our hospital because of heart failure. Her STS score was 8.8%. And this is based on transthoracic echo. LV function was normal. LV DDDS was 45.23 millimeter, and the ejection fraction was 58.7%. And the LA is very dilated. Its diameter is 53.7 millimeter, and MR was severe. ERA was 0.35 centimeter square. So this patient has symptomatic severe atrial functional MR, and her surgical risk is high, so we decided to perform mitral clip for this patient. And the procedure was very straightforward. We deployed one XTW clip here, and CBMR became just trivial. Now we can use mitral clip G4, and its procedure is very straightforward, 30-minute or 40-minute procedure, but we have some challenging point for atrial functional MR. Here I show 3 topics. First one is definition of atrial functional MR. What is atrial functional MR? And the second one is the subtype of atrial functional MR. There are two types, flat valve type and hamstring type, and also clip selection. Now we have 4 types of clip, so which clip works very well. And the third one is atrial functional TEER, not MR. So TEER is very important factor when we decide a treatment option, surgery or mitral clip. So first topic is definition of atrial functional MR. This slide shows echo criteria across different studies. So as you can see here, one study used the definition for atrial annular size, but others not. This is very difficult point when we start clinical trial for atrial functional MR, because each study used different criteria. But last year, one suggested definition was published from Jack review. This is just a suggested definition, but it's very simple and reasonable. First one is MR with structurally normal mitral valve leaflet. It means MR is not primary MR. And the second one is LA dilation. It's defined as indexed LA volume is over 34 cc. And the third and fourth is LV function. It's normal index LV endovascular volume, normal LV size, and LV ejection fraction is equal or over 60%. So 60% seems like a little bit high, but if patients have MR, there's a risk to overestimate ejection fraction, so it seems like reasonable. And this definition is just suggested definition, but it's very helpful when we start a clinical trial. And second topic is subtype of atrial functional MR. there are two types, flat valve type. Here you can see both leaflet have enough length and moves dynamic. Today's live case. And the second one is hamstring type. Usually posterior leaflet is very restricted and short. So it is not clear that these two types are different disease or hamstring type is developed from flat valve type. But recent echo study showed mechanisms to generate atrial function MR. When patients have develops AFib, of course, LA is dilated and also leaflet growth. It's called leaflet remodeling, and also the posterior leaflet touching to annulus deviate to outside of myocardium. Then it creates an atriogenic tethering. If atriogenic tethering is strong, then mitral valve tend to become a hamstring type. And if mitral valve leaflet growth, leaflet remodeling is strong, then mitral valve tends to become a flat valve type. But anyway, when we see patients with a symptomatic severe atrial functional MR patient, then we consider mitral clip. In that case, the other topic is which clip works very well. So in my center, for flat valve type, I use NTW or XCW. It's based on side length of the leaflet and mitral valve orifice area. I use cutoff point for mitral valve area is 3.5 and 1.2 centimeter for length of the leaflet. And for hamstring type, I use NTW because usually the posterior leaflet is very short and restricted, so I don't want to injure posterior leaflet. But when I face the difficulty to decide which clip works very well, NTW or XCW, in that case, I select NTW because it's a very safe clip and works very well. So this is 81 years old lady with flat valve type. It's not so wide jet, so with one clip deployment, MR became just trivial. And this is 83 years old lady with flat valve type. Here, jet looks like a little bit wide, but with two clip NTW clip deployment, MR became mild. So if clearly patient has a very large mitral valve area and enough length of leaflet, I straightly use XCW clip, but otherwise I use NTW. The final topic is atrial functional TEER. So left side is atrial functional TEER. This is caused by annular dilation. So valve looks like flat, same as atrial functional MR. But this right side is functional TEER. This is caused by pulmonary hypertension from left-sided heart disease. So these two types of TEER is different etiologies. So the response from mitral clip is also different. So this paper is from Cedars-Sinai Medical Center. So this figure shows severity of TEER after mitral clip. Here, right side, this is a ventricular functional MR patient. So after mitral clip, severity of TEER gets better during follow-up. But when we see atrial functional MR, it is not, because this TEER is caused by annular dilation. It's not from a left side heart disease. So when we see atrial functional patient with severe, significant atrial functional TEER and also symptom of right heart failure, when we see those patients, I send those patients to surgery because we needed to fix both valves. Otherwise, after mitral clip, patient develops right side heart failure. But now we have another new weapon. So this is a TriClip. So the tri-luminate pivotal trial 1 year data was presented at this year ACC. And in this trial, TriClip shows sustained TEER reduction through 1 year. So it means this TriClip may expand the indication of mitral clip for atrial functional MR patient. So this is conclusion slide. Thank you very much.
Comprehensive review of the atrial functional MR. So is there any quick question? Because we have a limited time.
잘 들어, posterior.
Otherwise,
anterior.
I think we can move on to the live case. Yeah. Dr.
Yes.
Kang, can you?
Yeah, I did not deploy.
Oh,
and
Yeah, we
catch-
move
catch
clip
one
more
time,
laterally.
a little bit laterally.
During the lecture.
And I think it's
You
actually
move?
good. Yeah,
Yeah,
we moved
we did.
a little bit.
Yeah,
Can you
yeah,
please
color
show the
please.
color? And became even better.
Oh.
Yeah, but it's better than before.
A little bit we moved to laterally. Good. And now I will deploy the clip.
Yeah, the posterior insertion is good. We have checked anterior insertion finally, and then deploy.
I think the position is better, and also the leaflet insertion of the posterior leaflet is also better
Yeah.
than previous.
There was some magic during the lecture.
How about anterior?
Yeah, anterior also looks good.
So did you record grasping?
Yeah, but
Did you record?
no.
It was magic point. Moment of magic.
During the
Yeah.
grasping, Dr. Matsumoto in the conclusion, we hurried up.
Okay, then I will deploy the clip. Let's see the final moment. 1, 2, 3, 4, 5, 6, 7, 8. Let's see.
Color, please, Dr. Kim.
Yeah, color press.
Oh.
Yeah, the color is same with the previous one, but just one difference is after deployment. Yeah, we expected the increase in MR after deployment, but the increase in MR, but the degree is the same as before the deployment.
Can you please leave the echo?
Okay.
Yeah.
That's a mild MR and the 3D zoom.
Yes, it looks better than previous location.
Yeah, I believe.
If you release a previous one, maybe MR is greater than moderate.
Yeah, I agree. Yeah, looks good in 3D imaging.
And we want to fluoroscopic image too, Dr. Kang.
Yep. This is fluoroscopic image from AP. And this is the RIO angle. Can you see?
Looks very good, yeah.
Yeah, looks good.
Very stable.
What was the LA pressure?
This is LA pressure. Can you see? Okay.
We cannot see.
The baseline pressure is still 20, but you can see the V wave peak is now reduced. Maybe with the procedure and volume overload and a little bit good, but you can see that the disappearance of the V wave. Also, the pulmonary flow is okay.
You may want to try to cardiovert the patient.
Yeah.
Yeah, the insertion is very good in this image.
And in second try, did you use a PEEP or independent grasp or some other technique?
We increased the PEEP.
Increase the PEEP.
Increase the PEEP.
And no, the independent grasp was done.
Yeah.
Okay, because the time is up, and I'm happy with this result, and we could do it
looks good.
for the
Just
many
mild
expert moderator and panelist opinion and help. Thank you so much.
Oh, excellent case. It was very good.
Thank you very much.
So let's move on to the previous coronary case. I think Dr. Kim is ready to show the final results.
수고하셨습니다. 쌤 뭐 더 넣을 거 아니시죠?
Dr. Kim, can you hear me? Yeah, go ahead.
So previous case was a toughest case, 88 years old male with ejection fraction 22%. That was improved this year up to 40%. The symptom recurred, thus we took angiography on RCA, mid-RCA, proximal RCA stenting was patent, but mid-RCA balloon site is restenosed, as you can see here. Thus today's target is LAD, calcified lesion. But before LAD intervention, we did a balloon angioplasty at mid-RCA. It was very tough to advance the balloon, 2.5 balloon there, because of the tortuous calcified and pre-stented segment. But high inflation balloon, twice or three times, results here. Thus, we were able to over to the LAD. Here's a LAD angio. First, there are three targets. The first, proximal LAD is very tightly stenosed in another view. Second target is mid to distal RC, heavily calcified, tortuous tandem lesions. Third target was big diagonal branch. Thus, I tried to, here's a radiocaudal view. Proximal LAD lesion looks less severe, but here we can see the proximal LAD lesion very focal, tight. And first, I tried to introduce rotor wire into the distal LAD, but it was impossible. Thus, I tried to balloon mid to distal LAD, but it was impossible. Even we use 1.0 balloon. I also use Corsair to support, but it was impossible to pass the rotor wire, even though it was possible to advance the Sion wire, but rotor wire was impossible because of high fraction resistance. Thus, I first target proximal LAD tight lesion, ballooning. After ballooning, then I implanted 30 by 18 onyx stent with secure left main ostium coverage and inflated balloon. Maximal pressure with left main ostium covered. It's another maximum pressure. Then I treat the first target and retry the second target mid-LAD, but still it was impossible to advance the rotor wire, even though I use Corsair, Guidezilla, and many things, but it was impossible to advance 1.0, 1.5 balloon through the mid-LAD to distal LAD. Thus, I tried to intervene big diagonal, but the panels insisted to target the second target. Thus, I repeat once again ballooning, but it did not reach distal LAD with support of Guidezilla, ballooning, and advanced Guidezilla, but it was impossible to pass until the distal LAD. Here is Guidezilla and Corsair, but it was impossible to advance furthermore. Here. Thus, I tried to treat the third target, big diagonal ostium, with ballooning to 0 balloon, but even balloon is not easily passed through because of tough calcification in proximal LAD. Thus, I repeated several times the ballooning with dissection of LAD diagonal ostium. I tried to advance on X 2.5 by 15, but it was impossible because of the poor guide wire backup. Even I can introduce the balloon, but it was impossible to advance the stent, even after maximum inflation of the proximal segment here. Thus, I exchanged guide wire into amplets, and then once again tried to ballooning the lesion that showed recoil, and maximum inflation here. Then it was possible to advance the stent with the support of amplets. hard lesion at the ostium of diagonal. This is a final angio after left main to LAD stenting and proximal LAD to diagonal stenting. As we can see, even though we did not treat mid to distal LADs, tandem calcified lesions, but we were able to treat left main to proximal LAD and big diagonal. As you can see, the territory of myocardium supplied by LAD and diagonal is not so different. So with this treatment, I expect the patient's ejection fraction may improve further, and I try to expect the patient's symptom may disappear. Okay, this is really a tough case, so I used IABP as a backup solution. During procedure, the blood pressure increases or decreases down to 80 or 70 with the support of dopamine. But finally, after treatment of proximal LAD and big diagonal, the blood pressure increases. Thus, patient got stabilized.
Yeah, thank you. Thank you for your very interesting and very exciting case. Yeah, so congratulations, the final result. So I would like to close this session, and thanks for all panelists and operators and sharing very wonderful case in this session. So thank you.
Thank you.